Hello, everyone. We're going to get started in just a moment. Thank you for your patience. Hi, everyone. Welcome to Research Update on Metastatic Breast Cancer. I'm Christine Benjamin, the Breast Cancer Program Director at SHARE. That was my dog, Maddie. Before the presentation begins, I'd like to tell you just a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Hahn and Dionna are finished presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, please remember that the presenters are unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. So now I'd like to introduce our speakers. Dr. Olwen Hahn is an associate professor at the University of Chicago Medicine, where she specializes in the diagnosis and treatment of breast cancer. Currently, she is the Associate Section Chief for Outpatient Clinical Operations, Professional Development, and Engagement in the section of Hematology Oncology. In addition to her clinical roles, Dr. Hahn serves as the primary investigator on multiple studies that examine the effectiveness of new drugs in breast cancer. She's active on a national level as she currently holds the role of Director and Principal Investigator of the Alliance Central Protocol Operations Program. In her role, Dr. Hahn oversees the Protocols Office's development, activation, and conduct of national and international clinical trials. Dionna Koval is a metastatic breast cancer patient advocate. She was diagnosed with breast cancer in 2014 and later learned that she had stage 4 disease to the bones and liver. Her first line of treatment lasted until the beginning of 2020, and then she started her second line of treatment. Dionna is a DoD breast cancer reviewer, an LBBC Hear My Voice alumni, a Hispanic support group coordinator in Chicago, and a SHARE support group facilitator for the Hispanic community, among other things. Welcome both. Dr. Hahn, take it away.
Hi, thank you so much for inviting me to do this, and this is a privilege to be able to give a update on metastatic breast cancer, and particularly do so with Dionna. So this is a special opportunity for me, and I hope everyone finds this informative. You know, an hour is clearly not enough time to talk about all the things we would want to, but here's a brief outline. I'll give some relevant updates for the 3 different types of breast cancer, talk about the study presented at our ASCO 2020 virtual meeting about the role of surgery in de novo metastatic. And then Dionna and I will talk a little bit about patient-doctor communication and what to do with this information with your cancer doctor. So starting with HER2-positive breast cancer. HER2 is overexpressed in about 20 to 25% of breast cancer, so it is a subset of breast cancers. And we have known, this is some data from the late 1980s, that patients with HER2-positive breast cancer, and HER2 is a protein that is over-amplified on the breast cancer cell, did not have as good of a survival as those compared that were not overexpressed or amplified. Fortunately, this has been reversed by the development of the monoclonal antibody trastuzumab, which has high specificity to that HER2 protein. And this has been a big game changer in the treatment of metastatic HER2-positive breast cancer. Fast forward to 2020, and we now have 7 FDA-approved drugs that target the HER2 protein. So this is a big development and shows that how when we can identify a target, we are able to successfully develop drugs. These drugs are trastuzumab, pertuzumab. These are monoclonal antibodies. We have 3 oral pills that are lapatinib, neratinib, to Catnip that you take orally that are tyrosine kinase inhibitors. And then 2 novel, what we call antibody drug conjugates. TDM1 or Kadcyla has been one that we've been using for a number of years, and a recent approval of trastuzumab deruxtecan. Here is kind of a quick snapshot of how currently oncologists are approaching the treatment of HER2-positive breast cancer, with our chemotherapy, our 2 monoclonal antibodies being the first-line treatment with the taxane. And in the second-line treatment, we're using TDM1, as well as there's possibly a role for the recently approved to Catnip, capecitabine trastuzumab. And then in third line and beyond, there are several options. The ones that are highlighted in red are the ones that have been recently approved, and I will talk a little bit more specifically about each of those. So what has been new in the past 6 to 8 months? We had 3 new drugs approved: trastuzumab deruxtecan, to Catnip, as well as neratinib. I'm going to focus on the first 2. Trastuzumab deruxtecan, again, that is that drug antibody conjugate. What that means is it uses that HER2 as a honing device. The HER2 monoclonal antibody is linked to a very potent drug. And this is a very novel antibody that has a lot of excitement because it has what we call a high potency. It's a novel payload where the ratio of drug to antibody is quite high, 7 to 8, and it is highly permeable, meaning that it can not only affect the cancer cells that overexpress HER2, but it also can have anti-cancer killing effects on the surrounding cells in the tumor microenvironment. This drug was tested in the Destiny Breast 1 study. This was a phase 1 and then expanded to phase 2 study where they found the appropriate dose for it, and then they expanded the number of patients that were treated. This clinical trial was conducted in patients who had had prior treatment. They had prior TDM1, and a lot of them had at least median number of 6 prior lines of therapy. And this was a pretty sick population, with 92% having visceral disease and 13% having a history of brain metastasis. And what you see here is that there was an impressive response rate. The overall response rate was 61%, and that is very impressive given the setting that this drug was tested in. And what this graph shows you, each little bar is a patient, and so below the 0 is tumor shrinkage. We consider a partial response to be everything below the 30% line, and as you see, the high number of patients that are having significant tumor shrinkage, as well as the median progression-free survival, how long patients are living without their cancer growing, was about 16.5 months. Again, very impressive when you're treating a patient that has received multiple different therapies. There are some side effects with this drug. Primarily, ones that have a high level of concern are patients can develop interstitial lung disease in about 13% of patients, and that is something that we as oncologists need to be very vigilant about monitoring our patients on, as well as some degree of nausea, fatigue, hair loss, as well as low blood counts or neutropenia. So this was approved at the end of December last year. And trastuzumab deruxtecan was approved in patients who have received 2 or more prior therapies for metastatic breast cancer. One big problem in metastatic breast cancer, particularly in HER2 positive as well as triple negative breast cancer, is the presence of brain mets. Breast cancer has the 2nd highest incidence of brain metastases among all cancer. As you see here, patients with HER2 positive metastatic breast cancer have a 50% lifetime chance of developing brain metastasis, compared to 14% for hormone receptor positive patients. This is definitely remains a big treatment opportunity for us in oncologists. And there are many challenges to treating brain metastasis. Aside from considering things as surgery or radiation, our systemic therapies, there are challenges of a blood-brain barrier, which may prevent penetration of our drugs into the brain. as well as a lot of times patients with active brain metastases are excluded from clinical trials looking at novel drugs. And so many of the studies are underpowered, and we don't really know the true efficacy of drugs in this population of patients. However, we've some exciting results with this new tyrosine kinase inhibitor to Catnip, which is a dual inhibitor of HER2, meaning that it inhibits the HER2 intracellularly as it dimerizes for the HER2 or HER2-HER3. And this drug was studied in a clinical trial called HER2-CLIMB. And patients were enrolled in this HER2-CLIMB if they had received prior treatment with trastuzumab, pertuzumab, as well as T-DM1. One of the very unique things about this trial that we do not see in many trials is that it allowed patients with untreated brain metastases that did not need immediate local therapy, meaning they were asymptomatic, or they had previously treated brain metastases that were getting larger on the imaging scan. All patients needed to have a brain MRI at the entry of the study. Patients were randomized. All patients received therapy with trastuzumab and capecitabine, and there was a 2-to-1 randomization to tucatinib versus placebo. These results were reported out in December of 2019, where for the whole study, tucatinib improved progression-free survival as well as overall survival. At our recent ASCO 2020 virtual meeting, there was a presentation specifically focused on patients with brain metastases, where we see that tucatinib decreased the risk of progression or death by 52%. So this is pretty remarkable, and this is probably one of the first studies that's kind of powered to look at this patient population. Again, it also showed improved overall survival in patients with brain metastases. So this drug received an approval in April of this year, and it received an approval for patients who had received 1 or more HER2 regimens, and then actually the label included patients with metastatic breast cancer with brain metastases. I think there's definitely a key takeaway from this for the oncology trialist community that, we really need to take note, to take a lesson from HER2-CLIMB and consider broadening our eligibility criteria to include patients that are that more represents what our real-world patients are going through. And so, again, this is our first trial, randomized trial to include patients with untreated brain metastasis, and future trials should really consider embracing this broader eligibility criteria. So, Dionna, do you want to talk a little bit about what these results mean for our patients?
So I'm not sure if Dionna is able to connect to audio.
Okay. Well, maybe I'll talk about triple negative and we can see if, maybe I'll go on and then we'll see if she can join. How about that?
Great.
Okay, so the next subtype of breast cancer I wanted to briefly talk about was triple negative breast cancer. And what would mean when we say triple negative breast cancer is that the staining pattern of the breast cancer lacks estrogen, progesterone, as well as HER2. This subtype of breast cancer accounts for about 15% of breast cancers. It is primarily common in young women, women of African and Hispanic heritage, as well as patients having germline mutations in the BRCA genes. Historically, these patients with triple negative breast cancer do poorer than our ER positive or HER2 positive breast cancer, and they've had limited treatment options. Here is kind of the current paradigm of how we consider treating patients with metastatic breast cancer. For quite some time until recently, we primarily had just cytotoxic chemotherapies. Fortunately, through lots of efforts in drug development, we have also we're able to kind of further subtype triple negative breast cancer, because we know that triple negative breast cancers, there are multiple different kind of subtypes within there. In particular, patients that have a germline mutation for BRCA1 or BRCA2, they have options in called PARP inhibitors, which are oral drugs, as well as there are some emerging data for immune therapy that patients that are PD-L1 positive, this is a immunotherapy protein expressed, they may also have benefit from addition of immune therapies plus on the backbone of chemotherapies. One of the big studies that was announced at ASCO 2020 was the results of Keynote 355. And this is the study looking at pembrolizumab plus chemotherapy for first-line metastatic triple-negative breast cancer patients. And in this study, it was another 2-to-1 randomization where all patients received cytotoxic chemotherapy. These were patients that were newly diagnosed with metastatic triple-negative breast cancer, no active brain metastases, and their PD-L1 expression of the tumor, it was not a criteria for the study. This was looked at retrospectively. The patients were randomized to receive pembrolizumab versus placebo in addition to chemotherapy in a 2-to-1 fashion. And they continued on the therapy until their cancer progressed. What was announced was that the trialists of the study reviewed the patients based on the level of PD-L1 expression using something called the a combined score. And those that had a high level of PD-L1 expression in the tumor cells and immune cells of greater than 10 showed a clear benefit of the addition of immune therapy versus just chemotherapy alone, with a difference of approximately 4 months, so extending the median progression-free survival to 9.7 months versus 5.6 months. However, those that had a combined score of 1 or greater, did not have the statistically difference. And thus, in the overall population, this was not examined because it did not meet the planned statistical design. What we see here is this in the select group with a high level of PD-L1 expression, there is a benefit in the addition of immune therapy. And this study adds to kind of the growing body of evidence that we're seeing in our first-line metastatic triple-negative breast cancer. It builds upon the work of Impassion 130, where that was atezolizumab, a different immune therapy, was combined with nab-paclitaxel. And again, for patients that had PD-L1 expression by a different assay, an IHC assay, showed a benefit for the addition of the immune therapy. Again, when we add new drugs, we have new side effects. And with the immune therapy drugs, we are seeing the mainly side effects we're seeing are these what we call immune-mediated side effects. So hypothyroidism, pneumonitis, colitis, and some skin reactions. Also, even very excitingly, we have a new drug approval for patients with triple-negative breast cancer. This is a drug, another antibody drug conjugate called trastuzumab. It is using an antibody linking to chemotherapy. And in this single agent study, this is a drug that's been around for quite some time. In 2016, the FDA provided this drug with breakthrough status for triple-negative breast cancer due to some of the exciting results. And based on that, the company had a kind of broaden change of entry criteria for the study. And what they saw is that for patients that had received multiple lines of chemotherapy, metastatic triple-negative breast cancer, there was an overall response rate of about 33% in the single-arm study. And this is quite impressive because typically what we would historically suspect patients to have in this setting is a response rate of about in the mid-teens. So this is definitely an impressive drug. It is being further studied and compared to cytotoxic chemotherapy, and we await those results. So there is a lot of development and clinical trials for advanced triple-negative breast cancer because we recognize that there's definitely more work that needs to be done. Further work with immune therapy to better define which patients will benefit. Looking at our PARP inhibitors, either trying to see if they can be combined with either chemotherapy or immune therapy drugs. There are other antibody drug conjugates that are being studied in triple-negative breast cancer patients, as well as androgen receptor agonists. So a lot of work that we have still yet to do. All right, so I'm going to pause now and Dionna, or have you been able to join us?
Yes, I'm in.
Excellent. Well, excellent. So I talked about, the HER2 positive drugs, as well as you probably just heard the triple negative. And why don't you please give your perspective about what these studies mean for our patients and what excites you about this data?
Well, what's really exciting is the fact that there is a new treatment for triple negative breast cancer patients. That is something that we're always looking for. Even though I'm not triple negative, I have many friends who are, and I'm so happy that there's something else out there for them and there's more hope. And I feel like this is going to be a game changer for them. So it's very exciting right now. I'm sure many others are feeling the same way. And as for the first set of slides, I missed some of them, but I remember them from from us reviewing them the other day. I like all the data. It's coming in and it's making things seem more, it's more, it's something that we're all dying to see, because there's so many new treatments and such a good numbers that are coming out, and it gives everybody an idea of what they have next and what they could use. So with all this coming in for us to see, it helps us to keep in mind of what to speak to our own oncologist about.
Excellent. All right. Right. And it's definitely exciting to have so many options. And I think as a oncology community, we need to have lots of continued work to better select patients for specific drugs. So our work is not yet done.
No, it's not, but there is a good standing right now. So
Excellent.
It's something to look forward to.
Excellent. So I think let me go on to, you can talk a little bit about the treatment of estrogen receptor positive metastatic breast cancer, which of course, by the numbers is the majority of patients that are diagnosed with metastatic breast cancer are ER positive. And, this is a type of breast cancer that there have been a lot of options. And one of the differences about ER positive breast cancer is that typically the first line options are pill or endocrine therapy based, meaning that the basis of the therapy is to lower the woman's production of estrogens in order to treat the cancer. And currently the standard of care, because of work done in the past several years, is to combine an endocrine therapy pill or backbone, typically an aromatase inhibitor, especially in postmenopausal women, with another medication, what we call a CDK4/6 inhibitor. And this is currently the standard of treatment for most patients. And in the past several years, we've seen 3 of these drugs approved: palbociclib, ribociclib, and abemaciclib. And then last year, we actually saw an approval of elipsalib, which is recently FDA approved in combination with fulvestrant, which is a SERD, a selective estrogen receptor downregulator, for patients with PI3K mutations. And so again, in the treatment of ER positive breast cancer, we are needing to become more specific and do next generation sequencing on our patients to determine if they have this mutation. This drug was approved based on a SOLAR study. The study was called the SOLAR study, and most of the patients, because of the timing of when this study was conducted, had received endocrine therapy alone. So only about 6% of the patients in the SOLAR study had received endocrine therapy plus one of the CDK4/6 inhibitors. And so this is kind of a slide of the 3 different CDK4/6 inhibitors, and there is definitely these different series of trials, the Monarch studies, the Paloma studies, or the Mona Lisa, depending on the different drugs. But we see here is about each of these drugs in the first line setting contributes to a median progression-free survival between 25 and 28%. 25 and 28 months for patients. So, and similar kind of efficacy, although, they have not been compared head to head together. Previously, this Falcon study had been announced where fulvestrant, which is an injection-based therapy, and that is that SERD I just discussed, was actually a little bit better than the aromatase inhibitor pill for patients in first-line ER-positive metastatic breast cancer. And this was studied in postmenopausal women who had not received any prior hormonal therapy. And so in this, fulvestrant had about a 3-month progression-free survival benefit over anastrozole. And this data set is not mature yet for the overall survival. So the big question was, now in the landscape of CDK4/6 inhibitors, is fulvestrant plus the CDK4/6 still the, would that beat out the anastrozole or aromatase inhibitor plus a CDK4/6? And this is the Parsifal study that was just announced at ASCO 2020, where they looked at that question combining palbociclib with either fulvestrant or letrozole. And again, these were patients with metastatic breast cancer. And in this study, what we saw is that there was no difference in either the letrozole or the fulvestrant when combined with palbociclib. So when you add the CDK4/6, the difference between fulvestrant and letrozole does not matter. Excuse me, I'm going to plug in my computer before it dies on me. So okay, so kind of getting back to the issue with the patients with the PI3K kinase, one of the unmet needs, as I mentioned, is that we really didn't know how active elipsalib was in patients who had already received an endocrine therapy plus a CDK4/6 inhibitor. And so this actually nice data set came out of ASCO 2020 this year, that for patients with this PI3K mutation who progress on the standard CDK inhibitor, this was in the BYLieve study, which is a very nice demonstration of the efficacy of this drug. And so this was a open label, it was a non-comparative study where patients would receive either elipsalib plus fulvestrant, elipsalib plus letrozole, and it was looking at the proportion of patients that were alive without disease progression in 6 months. And again, so it met its primary efficacy at 6 months. In this combination of receiving, patients had received CDK4/6 plus AI, 50% of them were alive. And so again, we think now this kind of study provides evidence that we should be using elipsalib in this population of patients after the CDK4/6 inhibitor. All right, Dionna, I'm going to turn it over to you to talk a little bit about what this has mean for you as a patient.
Since I am ER positive, I did start with you with the fulvestrant, and I used that treatment for what, 5 years?
Mm-hmm.
And now I just recently started the Ibrance and letrozole. So this is good. I like all this data because it helps me realize that how much time I have per the data before progression and how much better this treatment's going to be for me than the previous one. And I feel like I'm going to have a good chance of not having progression for a longer period of time. So this is exciting for me. And I know a lot of people are ER/PR positive, and I think that they would feel the same way. But this information is very helpful, and it is eye-opening to know what the differences are and what else is out there in case this fails.
Gotcha. Excellent. All right. And, I think, as opposed, we don't have any new drug approvals this year, but we've had there's been so much great work going on in the ER positive space that I think now there are lots of new drugs that are being evaluated, looking at SERDs or looking at AKT inhibitors, or actually the question of endocrine resistance is a big area of investigation. And so there's a lot of work that is going on for ER positive patients to continue to improve their treatment outcomes. So the last topic I wanted to talk about was the study that we've been waiting for, kind of looking at the question of the role of surgery for patients who present with de novo metastatic breast cancer. And so, patients that present with metastatic de novo breast cancer is about 6% of those newly diagnosed patients. And based on some prior retrospective studies, it was hypothesized that local regional treatment, that is removing the primary breast tumor through surgery, possibly adding radiation, may be better in combination with systemic therapy than not doing so. However, we recognize that these studies were biased because they were retrospective, they were not controlled, and they tend to have younger women, healthier women, patients with smaller tumors, the ER-positive disease, and a lower metastatic burden. And there's been, debate on the pros and cons of, why one should consider doing local regional therapy on the primary tumor in metastatic breast cancer. And some of the pros that people cite is the prior retrospective studies, that it eliminates the primary tumor that could be a source of distant metastasis. It reduces the likelihood of uncontrolled local regional disease, and it could potentially improve the quality of life. Where people on the cons for this was that, well, survival for all metastatic breast cancer patients have really, all the subsets have improved over the years based on better systemic therapies. Again, the selection biases of the prior studies. And doing surgery, exposes patients to potential toxicity and the side effects of surgery, as well as it adds to the healthcare cost in our country. And one of the more other concerning things is that we may be delaying or depriving patients of systemic therapy for the period of time that they are undergoing surgery and healing from it. And that may actually be to their detriment. There have been 2 studies in the past that have looked at this. Well, there have been multiple studies, but some of the more recent studies, one that was done in India that had no survival advantage. However, this was done in a resource-constrained area, and so some of the therapies that the patients received were not therapies that are available to our patients in more research-rich countries, as well as there was a study done out of Turkey that did show a favoring of doing local regional therapy. However, this US-based study led by the ECOG cooperative group was designed to look at this question. What it did, it registered about 370 patients that were diagnosed with de novo metastatic disease. And if the patients did not have progression following systemic therapy of between 4 to 8 months, they were randomized to either continue on systemic therapy alone or undergo local therapy of surgery followed by radiotherapy. And so about 360 enrolled, about 250 went on to be randomized. The biggest reason for kind of patients dropping off right here was that their disease progressed. So at the end of this study is, and I think the notable thing about the study, this was primarily a US-based study, so it takes so patients are treated as all of our with systemic therapies that are available to patients in resource-rich countries. But the results of the study revealed that there was no improvement in at a median time of 54 months in overall survival, progression-free survival. And particularly, there was no improvement in overall survival for patients with HER2-positive disease or ER-positive disease. And so you see the lines here overlapping. And in fact, although this was a small number of patients, patients with triple-negative disease kind of tended to have a worse outcome if they were to undergo surgery. One of the differences was, though, that patients that did get early local therapy had a reduced likelihood of progression at the primary breast versus those that just did continued systemic therapy. So I think with this data, from the ECOG study, we have a contemporary data set that shows that local regional therapy does not improve survival. They also ask patients questions about their quality of life. And what they found is that local regional therapy also does not improve patients' quality of life. However, we do know that patients that were receiving systemic therapy alone, about 20% of them did require local regional therapy for palliation or progression And so I think at the conclusion of this is that, local regional therapy should be reserved for these patients that become symptomatic or progress in their primary site. However, I think, there are still so many unanswered questions about patients, what we call de novo oligometastatic breast cancer. This is a subset of patients with metastatic breast cancer who have 4 or fewer metastases. And I think this is this group of patients, the role of local regional therapy is still under investigation in several trials. We will learn more about that in the future. So I'm going to turn this over to you to talk about a little bit about what this means for patients.
Actually, I was considering doing the surgery. But after reviewing this coming out from ASCO, I decided against it. It wouldn't benefit me like I thought it would. And I think that patients need to take into consideration all the pros and cons before they make this decision. And to be off therapy for a couple months, it isn't beneficial. And to be the quality of life that we all want is to be quote unquote normal. And in my mind, that was making me normal by considering the surgery. But in the end, it's not going to benefit me, and not to be on my treatment or have the side effects from surgery and whatever else comes with it, that would mess up my quality of life for that time being. So I'm just going to stay where I'm at. It is good information, and like I said, it's something that every patient needs to decide for themselves and how they feel about it.
I think that's a perfect lead into our next thing that we wanted to kind of talk about is, so here we have some updates, some new data, new drugs, and how can you as patients discuss these new therapies and data with your cancer doctor? So Dionna, I'm going to let you kind of lead the way here.
Dr. Hahn, the relationship I have with you now is unbelievable. I trust in everything that you tell me. I'm able to speak freely and tell you, okay, this is what I heard. What do you think? And I think when you get to that point in your relationship with your oncologist, it makes things so much easier. But you need to bring these questions and ask your oncologist whatever's on your mind. You should feel free to do that. And I appreciate that. You wouldn't believe how much.
Thanks. Well, I think, right, as you discussed, since we had this long-term relationship, you feel comfortable asking me these questions. And when you hear about new data, we always have a discussion about it. And some of the things that we talked about as we were preparing for this webinar was to give tips to people about, how to do so. How do you know? Invariably, you'll hear things in the news and the lay press, or your friends and family will tell you. And I think one of the things is that the message is, please, be proactive, ask questions about the new information, and ask your doctor how this information may pertain to you. But then I think the follow-up thing is, many times us as physicians, we don't communicate some of this information in the best or most understandable way for our patients, that we're used to maybe talking and using a lot of medical terms, but a lot of times that is not helpful to improve understanding for the patients. And if we give an answer and you don't understand, please ask for clarity. Go back and ask the basic questions. And I think that helps us as doctors recognize that we need to re-explain things in a different way in order to make things clear to our patients. Deonna, you had some ideas about asking your doctor, kind of preparing your doctor before the visit.
Right.
Send the questions via maybe my chart, email, to let them know what's on your mind before the visit, as well as maybe talk about some of the things that you do in terms of bringing family members, friends, and things like that.
I always go to my visits with my mom, or if she can't make it, another family member is with me. And the reason I do that is in case I miss something that you have said, because I'm trying to digest everything that you're telling me from the questions that I ask you. I need that extra person to catch something if I missed it. And I feel like if I send you my questions ahead of time, that will help you know what I want to talk about at our visit.
Yeah.
And that will help us get through it. You know, we have our little schedule done, and I know at the end of our visit, after my checkup, that you ask me, well, what do you want to talk about? What questions do you have? So that gives us that whole time where you're prepared for when I get there, that you'll be able to answer those questions. And to have that done beforehand, I think it helps you too, so you know what's going to happen and what I'm expecting.
Right. I actually find it very helpful to know in advance, just because, you know, there may be some information I hadn't heard of. I have a chance to look at it, but also it just lets me know what is on the patient's mind, and, you know, how we structure the visit to really address, you know, my patient's issues. So I actually really appreciate that. And then sometimes you even tell me, you're like, okay, that's great this time, but next visit I want to talk about X, Y, and Z. And that's great too.
Yes. Yes, I do. I already have them set up. I'm going to hit you with these questions, and then next month, this is what's going to come up. So you know what ahead of time.
Yes.
So it does help, and I write everything down. I bring my questions in just in case we miss something, just so I have them, and I could review them, you know, check it off my list that, okay, we talked about this, we talked about that. So, and even my mom knows what my questions are because I review them with her. So she knows what to expect to hear and what's going on.
So, right.
All those help.
Right. And you're right, exactly. An extra set of ears is always helpful. Or even if somebody can't be with you, because now I think with COVID, even for in-person visits, there are limitations on visitors in clinics. So, you know, asking your doctor to, like, you know, maybe have somebody in virtually with FaceTime, with the phone. Even if that can't happen, you know, even recording, you know, asking your doctor, do you mind if I record this so I can review it later, or so I can have my significant other or loved one listen to this, or other things. And some things we wanted to talk about was kind of, you know, communications for best practices. And I think, you know, as you mentioned, it's not, you know, you and I have known each other for many years, you know, and I think we have, you know, kind of come to appreciate some of the qualities of our patient-doctor relationship. And so I don't know, can you see the slide, or do you want me to kind of summarize the slide to talk about kind of communication best practices?
I could see the slide. I could see it.
Right.
I feel like when you're starting with an oncologist, there's going to be trust issues in the beginning because you don't know what to expect. You don't know what's going on. And it's hard for you to believe what you're going through as it is, and then to trust the rest of your life with somebody that you just met. You have to get over that. And once you do get that relationship, you have to be able to trust your oncologist. You have to come up with different ideas along with your oncologist and say, what about this and what about that? And things do change in your life. Everything isn't going to be the same. 1 month you have progression, the next month you don't, and it's gone. Planning for the end of your life, and if you want to have a DNR signed or not. And it's all these decisions that we as patients have to make, and we have to make them and trust in our oncologist to help us make that decision together. They're with us through this whole journey as well. And having them be there and understand to a certain extent of what you're going through, it's an ideal situation for me. Dr. Hahn knows about my family life. I know about her family life. It's just a relationship that we have grown into. And it might have taken some time, but we're there, and everything that we know about one another, it shows in treatment plans and conversations outside of clinic, being able to do a FaceTime with her. It's just a comfort level that you reach, and you have to be prepared to be open-minded on all issues that are going to happen within your journey. And this is just something that I hope other patients have the experience of having with their oncologist, because like I said, I'm very grateful for her, and everyone in my family loves her. She's kept me going 6 years. And, you know, when you read the stats saying, oh, you only have three years, 36 months, it scares you in the beginning. And to know that she fought with me along this way to keep me here and to keep me with my son. And that is so important to me.
Oh, thanks. But I would say you kept yourself here for 6 years. But I think what you're saying is it's definitely a great partnership. And I think the key things that you meant is that, you know, the presence, that when we have visits, that we are, you know, really focused on what's the importance to the other person, the trust, the collaboration. And that's not to say that every visit is jovial or anything. That, you know, during the journey of a metastatic breast cancer patients, there are going to be a lot of challenges and a lot of difficult conversations, and even differences in opinion between physician and patient. But I think, you know, if you have the understanding that, you know, you can be forthright and you trust the person to guide you for the best decisions, I think that can help kind of overcome the natural challenges.
Yes, it does.
The last slide, we just wanted to kind of mention, you know, for people who, you know, are interested in participating in clinical trials, you know, how can you do so? I think your physician's always a great choice to speak to them. If there are not clinical trials available in his or her office, you know, contacting a nearby academic center. They often have intake offices or web pages. Clinicaltrials.gov is a search engine, and actually a search engine that is a great resource, as well as looking towards your local and national advocacy groups. So
I love that.
Thank you both for all that information and a peek into your relationship that I'm sure is making many people on this webinar a little envious, wishing that we can all have a great doctor-patient relationship. I would just like to add about finding clinical trials. Right on the SHARE website, sharecancersupport.org, there's metastatic trial search. So if you put in some information, a clinical trial, you'll be matched with a clinical trial, and the clinical trials listed in there are specifically for metastatic breast cancer. And also, MBC Connect is an app that has been developed by the Metastatic Breast Cancer Alliance. And if you put in your patient information, your treatment history, you'll be matched with clinical trials that you may be eligible for. You can take that list and go right to your doctor and talk about potential options for you. So thank you both again. We have a couple of questions. Let's start. A couple of questions about ER-positive breast cancer. So what is the second line of treatment for ER-positive, HER2-negative metastatic disease after the first line CDK4 inhibitor and fulvestrant fails? What's the second line treatment?
So that's a great question, and the answer is not straightforward. I think what we now know with the elipsalib approval and the PI3 kinase mutation is that all ER-positive patients need to have genomic sequencing. So that's where a piece of tumor is undergoing sequencing, either in a commercial lab or sometimes at University of Chicago. Our pathologists have a molecular lab that we do sequencing. Sometimes if there's not tissue available, we can do liquid biopsies, which is a blood draw. And so I think, if patients have a PI3 kinase mutation, then using that inhibitor would in most cases be the appropriate second line. There is a lot of questions about endocrine resistance and, this is ESR mutations in your clinical trials, looking to study to drugs in that space. So I think it really, there's not a real blanket statement I can say like HER2 that this drug is the best second line. I think it really depends on the tumor genomics for the patients, as well as kind of what is going on with their disease in terms of where they're progressing. But I think the conversation is going to be between further lines of endocrine therapy or possibly whether chemotherapy will play the role. And I think the tumor genomics and the individual factors will play a role in that decision.
So this is a question that gets asked pretty often, and hopefully you can answer it. So someone's asking, is there any benefit to using another type of aromatase inhibitor and or a CD46 inhibitor after being treated with them and also after having chemotherapy?
So again, I think that is a question that gets asked a lot, and it is a I think there's not a straightforward answer. So most of the large studies that have been reported and the approvals are based on, you know, this is a patient's first CDK4/6 inhibitor. You know, there is not a lot of large scale trials that have been reported out looking at kind of using another drug afterwards. There are definitely a variety of kind of, I would say, retrospective looks or case series coming out. I think some factors that will go into the decision would be, you know, if a patient was not able to tolerate a particular CDK4/6 inhibitor, like palbociclib, due to their blood counts being quite low, and they weren't able to take an adequate number of the dose, and so it may be reasonable to consider like another one, such as abemaciclib, which tends to have more GI side effects, is not as much neutropenia. But again, I think I don't think that's a blanket statement that we can apply to everybody. I think it really depends on kind of some of the treatment history questions. And I would say typically we don't seem to kind of cycle through the CDK4/6 inhibitors. We would try to find another drug that line of therapy that would be proven to be a little bit more effective.
Thank you. What about any updates for lobular metastatic breast cancer? It seems to be a population that doesn't get a whole lot of interest.
Right, that's definitely a smaller population. I think it's going to be 20% or less of patients. A lot of times they are included in, you know, these larger studies that are reported out. But there's such a small number that in each study that it's hard to make statements about them. So, you know, unfortunately there wasn't anything in ASCO 2020, any of the big oral abstracts that focus on lobular cancer. And at this time, we don't have any specific therapies.
And a couple more questions for you, and then there's a question for Dionna as well. So what's the status on the new oral fulvestrant and also the new oral trastuzumab?
So the new oral fulvestrant, or the oral SERD. So this fulvestrant is the SERD, selective estrogen downregulator. There are oral versions of that that are being tested. So there's lots of clinical trials, and it's in the advanced phase of testing. So I think stay tuned. We will hear more about that in the future. There is not one that is currently approved by the FDA yet. So in terms of an oral the oral drugs that target the HER2 are the Catnip and neratinib, or the newer ones. Those are tyrosine kinase inhibitors. In terms of there's a different form of trastuzumab. So trastuzumab is an IV form, and in recent years, actually, there's been several biosimilars on other IVs that have come out and been FDA approved to be shown to be equivalent to the reference product of trastuzumab, as well as there is a subcutaneous form that has come out as well. So instead of a IV, it's a subcutaneous injection that is, you know, has been FDA approved as well.
Okay, and There's one question about brain mets. So why are MBC patients not given a baseline brain scan prior to developing symptoms that may indicate brain mets?
So I think that is a fair question. There are some tumors like lung cancer that, most patients are part of the staging workup is CNS imaging. I think in terms of that slide I showed you, the different percentages of brain metastasis for metastatic breast cancer patients, I think for ER positive breast cancer patients, the percentage is so low, less than 15%, that we typically don't do screening unless the patient does have symptoms. For HER2 positive and triple negative breast cancer patients, it is a higher percentage. It is 45 to 50% of patients in some series. And so in those situations, it definitely may be warranted to consider some imaging, and some clinical trials are requiring that.
Thank you. And Dionna, someone's interested in the advocacy work that you do in the communities that were mentioned in your bio. Can you talk a little bit about how you got involved in providing a support group for Spanish?
Well, I became involved because I did a program through Living Beyond Breast Cancer called Hear My Voice. And that showed me the importance of speaking up about my diagnosis, and it showed me the importance of, within my community, breast cancer is, I live in a predominantly Hispanic community. So it is kind of taboo in a way to talk about it amongst others. So for my project that I did with Living Beyond Breast Cancer, I went to my local church down the street and asked if I would be able to start a support group for the Hispanic community. And that's how I got started. I don't speak Spanish very well, but I had somebody working with me who would translate stuff that I couldn't say. And the whole group is not just Spanish speaking. We have English speaking and Spanish speaking. And it started out as, a couple women here and there, and it's an open support group. So you could be stage 0 or you could be up to stage 4. It's not just metastatic. And a lot of these women were getting comfort in being able to talk about their feelings, stuff that they're not able to do at home or speak to their families about. And we were able to communicate as a group and share what we all go through. So it helps them. And because of COVID, we haven't been able to do anything. But we're trying to get back into it through technology. A lot of women don't have it on their phones. They don't feel comfortable doing Zoom calls. But as long as myself and my partner, both, we check up on everybody, I think they're comfortable to that level right now. So we're trying to move in a direction where we'll be back to that support group and be able to help each other once again. But that's how I started my advocacy work.
Thank you, Dionna. I think you bring up a really important point, right? You said you literally went down the street to your church, and doing that and walking down the street and asking to do something to help the community, you're making a huge difference.
Yeah.
Thank you.
And now I am going to be working with SHARE, doing a Hispanic group under the SHARE umbrella here in Chicago. So it's very exciting that this is building up and we'll be able to help more people. So I'm excited about it.
Not more excited than we are to have you. So thank you both so much. Thank you for your time and your information. Thank you to every participant and those of you who asked questions. I'm sorry we didn't get to all of them. The webinar has been recorded and it will be available on the SHARE website, sharecancersupport.org, probably within a week or two. Thank you so much. If you wouldn't mind, at the end of the webinar, just taking that survey and letting us know what you think. It helps us with our future programming. Thank you, everyone. Thank you, Dr. Hahn. Thank you,
you.
Dionna.
Thank you.
Bye, everyone.
Bye.